Now Dr. Surya Prabha will introduce Professor Ambedkar.
Professor Ambedkar doesn't need any introduction in any part of our country. He is indeed the Sachin Tendulkar of Indian pediatric practice. He served IAP as national president. He is an excellent clinician and powerful speaker, but in very simple in expression. Though he is retired as professor.
To have a rationality in our approach. I'll take you in the next 25 minutes of how we need to really look at fever. I think most of the times the parents feel that the fever is a curse, and for some reason or the other, therefore, a pediatrician is expected to bring down this temperature instantly if possible. We should not forget that fever really enhances immunity, and therefore fever is certainly beneficial. Everything that is beneficial could be harmful, but in prima facie, the fever is really beneficial. And to that extent, we need to realize how much we need to suppress each time we met fever. We know that fever has been mostly a friend, and there is enough literature support right from ancient time when we know that fever is protective, it inhibits pathogens. We know that there is a higher survival rate in febrile septic patients than hypothermic patients. We know that pre-antibiotic era, a disease like neurosyphilis was treated by inducing fever. And finally, to a clinician, a fever pattern is a clue to diagnosis and may be blunted by potent antipyretic, which often causes delay in the correct diagnosis. Look at the yesteryear's physicians who could talk of fever as remittent, continuous, intermittent. Now every fever is a non-existing fever. You give a paracetamol or even more powerful antipyretic and the patients have no fever. What kind of approach we have when the patient's fever is totally blunted? And I think to me as a clinician, when a child is running fever, it gives me a definite clue to a pattern of fever that probably would be very useful for a rational approach. But then can fever be really a foe? Yes, it could be. If you have a hyperpyrexia, then fever may induce simple febrile seizure. We know generally it's a benign condition, and not every child who has high fever really gets into a simple febrile seizure. And neurologists tell me now that even if somebody gets a simple febrile seizure, next time you keep the parents busy with controlling fever, but that's not a guarantee against a simple febrile seizure. Quite a complicated issue in a simple febrile seizure. We need to tell the parents that keep them busy reducing fever. Well, fever may worsen or manifest a pre-existing condition. I'm sure that you have a very sick child in an ICU, that fever might add on an extra burden to his metabolic problems. But to me, fever represents an occult serious disease, and we know that fever does result in increased water needs, and if not anything, it certainly causes discomfort. So now knowing that fever is very useful, is beneficial, it enhances immunity, but rarely it may cause some more trouble. Let's see whether should fever be suppressed. I think fever is beneficial, but beyond certain limit may be discomforting or even harmful. I tell the parents of children whom I see with fever that if it is around 102 or less, it is beneficial and it often causes no discomfort. Most of the mothers would tell you that the child is running about in spite of fever. In fact, that behavior of a child makes me as a clinician to understand that very likely the cause of fever is not serious. On the other hand, you may have had mothers who come and tell you that, doctor, the fever is not much, but the child is rather dull, apathetic, drowsy. Now that bothers me much more. Therefore, within limits, this is not to be worried about. If the fever is going higher, it's still beneficial, as we said it is, but it could be causing discomfort. And therefore, what do you treat this fever? Take away discomfort, but not take away fever. And I think unless we counsel parents to say, each time I see a child with fever and the parents ask me how long it's going to take, we need to kind of counsel them and say that it will take its own course, especially if it's a viral infection. And each time they say that you give paracetamol for 4 hours, the child is all right, he gets fever again, which certainly means that there is a infection which is still lurking And I think it's when the parents expect something miraculous and we fall prey to their demands, trying to really meet their demands, that we get into trouble on a rational approach. I'm sure a millionaire who suffers from a fracture still sits in a plaster for 2-3 months. Same thing with a poor person. No millionaire asks an orthopedic surgeon to set his fracture right in a shorter time, maybe with an imported plaster. That doesn't help. And I think it's up to us to counsel the parents. And once we know that the fever is not damaging, I think the confidence that we exude to tell the parents, almost always the parents would follow. But if fever is going higher, then surely it may cause harm, in which case you certainly want to control fever to comfort and safe level. How do you do that? Certainly use an antipyretic, we know that, and besides that we use the supportive measures. I'm sure all over the country, moment the child has fever, parents cover him much more to prevent pneumonia or whatever. And when you're feeling cold, you also take a blanket. When you tell an educated parent that why do you have blanket for both situations? When you feel cold, you have a blanket. When your child is feeling hot with fever, you still use a blanket. Therefore, many such actions which are probably a cultural add-on to having a poor response to an antipyretic. And I think that's the time the parents say that the antipyretic is not working. Surely the lukewarm water sponge, gone are the days when you put something on the forehead. That used to only announce an ideal antipyretic. I think unnecessary, there have been debates in our country just because we feel antipyretic is against fever. So fever must come down. We know that a painkiller never kills pain. It makes the pain tolerable. Even then it is called painkiller. Antipyretic is one that does not bring down fever to normal and should not bring down fever to normal, but it should make the fever comfortable and safe. Unless we put this across to the parent expect that the temperature should crash down to normal. To that, I think we need a short-acting drug. There is no point in having a drug which acts for 12 hours when the fever may not come again after one episode. You need therefore a short-acting drug so that we can repeat the dose as many times as you want. Efficacy, as I said, of fever to normal is not ideal. You have a paracetamol, which is a time-tested antipyretic, and I almost never use anything else because I feel if the paracetamol does not work, only two conditions. One, either it's not given properly in an adequate dose, or the condition causing fever is serious enough. And I think both ways you are quite forewarned that there's something else you need to look at. On the other hand, if you just crash down fever with nice drugs, then I think you will miss many things. And as a pediatrician, it's not nice to see a pneumonia coming without fever. Mahesh Babu said, no fever is no pneumonia, bacterial pneumonia. But I see in my practice, pneumonia bacterial without fever, because nicer things are available and you can bring down fever but not pneumonia. Okay, the textbooks need to be rewritten that you have in India a pneumonia without fever. And therefore, I think it's important that we use a drug like paracetamol, and we know that this is very ideal, we will not go by that, but the best part is it could be used at any age, almost in any situation. What about other antipyretics? Well, I think ibuprofen is a useful alternative. WHO has considered it as good as paracetamol. I think in children it's not much of a problem of gastric irritation, and one might use this as well. But I think the other ones, including nimesulide, I think should be thrown out. I'm very sure, I forecast that it will have a natural death very soon, but not before probably some kidneys or livers are damaged and some pneumonias and meningitis are missed. There is no reason to use such an antipyretic at all, and this is not an antipyretic. Having said that, we know that we manage fever symptomatically, but what about the cause? You need to tell the parents that fever never kills, but it's the disease causing fever that may kill. And I think having decided how to control fever, we need to go next step to say, what's the cause of fever? You may have very low grade fever and the child may die. On the other hand, it's not higher the fever, the child has a higher mortality. The parents generally consider serious illness proportionate to a degree of fever. And you and me know that if a child is immunologically very potent, he is likely to throw up a high fever, and that is nothing really to worry about. How do I go in my clinical practice? As soon as I see a patient with fever, I need to anticipate seriousness for immediate referral. And I want to know whether this child needs to be referred right away or I hold back. If not serious, then I judge the probable cause. If the child has a serious problem, I don't think I need to waste time in deciding the probable cause. If we find that there is a probable cause that is evident, confirm if possible and treat. And we will see at each point of time when you confirm ideally. No cause is found, then a symptomatic treatment with close observation for 3 or 4 days, because you already got out of a serious illness. There is no hurry. And if there is no clue at the end of 3-4 days, then you order tests and then treat empirically, but not before you have ordered some tests. And if at the end of all that, if the fever persists, then you may have to refer to a specialist, not because he understands anything better than you, but you need to prove to the parent that he also is as bad as you are. So take that help, because I'm sure all of us know the same medicine. Who is better? Nobody is better. But I'm sure that as a senior pediatrician, we are at advantage. When I see a patient after 1 month of fever, 3 pediatricians having made enough mistakes, there is no more mistake left for me to create. And the parents feel that, oh, this man knows very well. So they said, next time when he starts fever, I'll come to you. I said, no, don't be in a hurry. You come a little later. So that is, I think, how we go about it. Let's see how we anticipate seriousness. I think age under 3 months high fever is serious, because you just cannot wait on, it's risky, you cannot write an antibiotic at all. You need to probably quickly. Yes, if you are a very confident clinician, you will see a viral infection even under 3 months. And you need to be very, very confident. You need to have a mother or another sibling having a viral infection. This child is breastfed, he is feeding well, he is behaving well, and he has a fever, cold, cough. You might call it a viral, but it's risky. Of course, change in behavior. What do you want to know for immediate referral? Under 3 months, meningitis, pneumonia, sepsis, inflammatory abdomen, diphtheria. I feel there is no another cause that will kill the child even if you wait for next 3-4 days without a diagnosis. But the child will be dead if you started a drug without knowing the diagnosis. And I think, I'm sure that Dr. Vijay Kumar will agree that UTI can wait for 2 days, but don't harm by giving an antibiotic on day 1. But a meningitis, pneumonia, sepsis, inflammatory abdomen, of course, surgical abdomen, guarding rigidity, etc. And a diphtheria, which I'm told is kind of resurging back in some pockets, need to be very, very carefully assessed. So what do I do in the first day of fever when I see a child? I just say that I have nothing of this, and in which case I try to now judge probable cause. Fever is acute infection till proved otherwise. What does it mean? There is no acute infection without fever. Chronic infections, of course, can come without fever, we know that. The pattern of fever tells me mostly, to me, episodic, unrelated to antipyretic is malaria. Now we all know that malaria in newborn is without fever, only hepatosplenomegaly. Malaria in an infant could be a low-grade continuous fever, yes. But I think in general, you would have some erratic fever. Onset and progression is very important. A typical bacterial infection peaks by day 3, day 4, unless it is a pus-producing infection like a tonsillitis, where you have a high fever on day 1. But look at a viral infection, generally a high at onset and in fact declining by 3-4 days. And therefore, as a simple rule, I am sure that those of you who are very wise know too many exceptions. It's nice sometimes not to be very wise and very well informed. Then you follow the rule, 99% you are all right. And therefore this is the rule. For me, a typhoid starts with gradual peaking by day 3, day 4, and I anticipated by day 3, day 4 the fellow should be better. So to me as a clinician in my office practice, I can almost differentiate viral from bacterial. Viral is upper lower airway, disseminated, and the bacterial is localized. I think even if we just go by that, we are almost always correct. What's the clinical evidence of a definite bacterial infection? Very rare. And therefore, you will not write an antibiotic in the first 2-3 days of any fever. Because unless you met a definite tonsilopharyngitis or an otitis. For an otitis, you need an otoscopic examination. Otherwise, you will diagnose even when the grandmother can diagnose. That means the pus flows out. And therefore, this is, I'm sure, I hope none of you wonder what is this new scope. Bacillary dysentery. If I see a high fever with blood and mucus, I would give an antibiotic. If I have an acute lymphadenitis, painful acute high fever, I need not wait for any test. But look at this. Except this, probably a UTI in an older child that I can pick up. And I quickly ask for a routine urine and then get on to an antibiotic. How often you meet this? Definitely. I think in a smaller child you hardly meet this. And therefore the rule would be no antibiotic in the first 2-3 days, especially if you have no seriousness. It will confirm. I think UTI is a must confirmation. We have had an excellent talk about that. Dysentery, it may be ideal to confirm, but I'm not worried because amoebiasis is rare in young children. So there is no need to use broad spectrum with all kinds of things together. It's a bacterial infection. Well, the confirmation is optional in UTI. If I see a tonsillitis, what confirmation? If I see a lymphadenitis acute, what confirmation? But barring this, there is hardly any reason to start an antibiotic. So we have already said when to treat. Symptomatic treatment we have already discussed. Now I have a child at the end of 3-4 days, no clue at all. Now I start looking at. Mahesh will agree with me that in an infant I would ask for a chest x-ray on day 4 because I'm not too good a clinician to pick up a small pneumonia. That might be in trouble. Well, you might look at CBC. I will just again highlight that this is very important. These are useless. Platelets are important. And we have learned how eosinopenia may be very useful. You may have a high neutrophilic leukocytosis in a systemic inflammatory. You have a neutrophilic leukocytosis even in an acute viral infection. We heard in typhoid you may not have leukopenia. So what does the count tell you? Very little. But maybe the eosinophils might tell you something much more. What empirical therapy you want to give? I'll talk about the empirical antibiotic therapy. But if I'm not sure in my epidemiology, chloroquine is a reasonable bet. But antibiotics based on, we have discussed how to choose an antibiotic. If the fever persists beyond 4 or 5 days and there is no clue whatsoever, I don't think any one of us is wiser. I just want to make a point that I don't do ESR very often. Especially in the first week, ESR has no use at all. Once I told an undergraduate that ESR is high even in common cold. They said, which textbook has given? I said, in textbooks they don't expect you to do ESR in common cold. That's why they haven't said it. It's too much to do it in common cold. Point is that in summary you have a fever as a desirable protective response. It's harmful to suppress it completely. Fever never kills except hyperpyrexia maybe. What may kill is the cause of fever. Hurry to diagnose probable cause rather than treat empirically. And I think you need to be in a hurry. And many times parents tell me that you asked me to observe, why don't you act? And action without justification is harmful. And I think we need to tell them that. Finally, when they don't understand, I tell them that you need a better doctor. Then they are confused. They can't ask me who is a better doctor. If they look confused, I tell them, if you find one, please tell me. The next patient can be guided. Thank you very much. Ibuprofen, mefenamic acid would be of the same kind because not only my hair are getting grey, but the grey matter is getting white, and therefore I remember only few drugs because I won't know the dose of mefenamic acid. Okay. That's why I don't try it. But I suppose it is as good or bad. And therefore I don't mind if somebody says I use mefenamic acid. I'm sure it's as good. But then I'm happy with paracetamol, so I don't even worry about it.
Sir, lukewarm wash, thorough wash, not only brings down the temperature, I feel it enhances the immunity also.
Well, I learned something much more today. Thank you very much, sir.
This is what I routinely do in such situations.
Excellent. I think from tomorrow I'll practice.
And it's quite
No, I think what you're saying is probably rational, but the point is that we need to use such measures.
and
they're
it
very-
quietens the baby also.
Yes, because it's very pleasant. You put somebody in that cold water, first thing there's a vasoconstriction and fever doesn't come down. Now if ice doesn't come down, bring down the fever, they will go for dry ice. That's too much. So I think we need to certainly
Probably that
impress
is the
them.
reason, even in acute distress, people are allowed to take bath.
Yes, I think when we are tired, we take probably a lukewarm water bath and we feel happy. I suppose the muscles which are tired certainly enhance the circulation, remove the toxins, and you feel better. So there must be a reason to make the baby more comfortable, but also, as you say, even enhance immunity.
Yes. Regarding the ibuprofen, sir, I have seen a child about 1 year plus. I resisted myself from giving ibuprofen and I gave one dose. The child reported with bleeding, gastric bleeding.
Well, I'm sure that these must be occasional things happening, and while paracetamol is far safer, I'm sure the other NSAIDs may have small problems, and I think the nephrologist would certainly not like any NSAIDs to be used in general, though fortunately we don't need to use long-term NSAIDs, but I think paracetamol is the safest.
I think in one of the sessions, I remember Dr. Srinivasan said high temperature over 103 and with leukocytosis, straight away you can go for an antibiotic.
I think I mentioned bacteremia in children between 3 months to 3 years of age, and it's one of the screening method, and then that is the way you have to decide about. That is accepted this thing. We remember Kadalur, that's ceftriaxone. That's bacteremia in that particular age group, where we have used one study which has been published also. So that is one way, instead of starting antibiotic in that particular age group where there is a risk of pyogenic meningitis in a few percentage of cases, about 6% of cases, then it has to be used. And of course Dr. Amdekar also has written in the emergency medicine about fear of unknown origin. So I think that is recommended.
I personally feel that if you time your test properly, you can interpret it better. In Bombay today, every head injury in a child is first CT scan. Because there are so many CT scan centers, you are likely to fall near the CT scan center. Okay. And first you do a CT scan and then go to a doctor with a normal CT scan. After 12 hours you are getting drowsy, but you say, but CT scan was normal. I said, brain was not normal, CT scan was normal. So I think sometimes the test has to be timed, and I personally feel that if I don't suspect a serious disease underlying causing fever, then I would wait for first 48 hours even before rushing. I might do a routine urinalysis on day 1. I think in a small baby with high fever, that's my first bet of a routine urinalysis, not even a CBC.
Sir, I see more number of febrile seizures around the new moon or full moon days. Is it it is my observation or
Pardon?
I see more number of febrile seizures.
I didn't get him.
High number of febrile seizures during new moon or full moon days. New moon or
I think if you add new moon or no moon and some part moon, then it would be true. Because I'm sure that the science may recognize some changes occurring in environment which we don't understand. And there are people who say, I get an asthmatic episode every time. Okay, there I tell the parents that if you have observed it, what will happen if you get an asthmatic attack at some other day? Will you treat or not? Yes. But I'm sure this is a thing that we don't know. If you really broadly see 3 paths, allopathics as we practice, we are after getting rid of the enemy. So we talk of bacteria, virus, fungus, etc. The homeopath talk about the host. They say even if America comes with a nuclear bomb, we will have our lathi or something ready. We will create a host competent. And the Ayurvedic physician talk of environment. They would say get up in the morning, before sunrise, take a bath and take this medicine. Okay. I think all three are important. We are rather ignorant about the other two. We are doing now a host study. We are talking about immunocompromised, immunocompetent. So I think we are bringing in that. We are also talking about the environment. We know rifampicin early in the morning on empty stomach. We talk about circadian rhythm. So I suppose that all along we gave an attention to only the enemy. Now allopaths are also giving a lot of attention to the host and the environment, of which we know little. I'm sure Ayurvedic physicians know more about diet and disease rather than we know. But we need to take from that. So I suppose there could be something true in this statement, but I don't know scientifically whether it could be considered as that. If that is so, then I'll give an oral diazepam or a frisium 12 hours prior and another day, so that would be.
Because of the risk of emesis, what has been the experience of the risk of emesis exists, as Dr. Birudagiri has said.
Well, Unichem earlier days when Mr. Modi was reigning supreme, he wanted to bring in a lot of suppositories, including bitter drugs like chloroquine, etc. And a market survey had shown that the rectal mucosa absorbs the drug, especially certain drugs, as quick as an IV. And therefore, if you push an IV diazepam, it would be as good as a rectal diazepam. I can understand a simple febrile seizure. When you are seeing a child seizuring, you could push even an intravenous preparation through a catheter per rectum, it will act as good. So there is an advantage of a quicker absorption through a rectal mucosa, especially in some drugs. Barring that, I think oral is far more convenient.
We have a group of children who refuse to take medicines. So for them, I think suppository, especially in fever, we've had some children who refuse to take any medicine. So in those cases, probably suppository would be of use.
Yes, but I know some of my family physician friends who give injection because children don't like to take medications. Now, you can't give injection of nutrients, okay, they have to use their mouth. So I feel that largely, I find that most of the mothers, and you are a better judge, know how to give any drug to her child. Okay, if the nurse comes and if I say, do it this way, that way, it may not be right. So personally, I feel even chloroquine, I have almost never used it in any other way except orally, and I'm sure most of you have done the same, and successfully.
Sir, only one question, sir. Regarding parental pressures, how do you manage, apart from the referral, other ways to manage parental pressures?
Parental pressure. I think the best way to manage any pressure is to pressurize the opponent. Okay, and I think what we lack is a confidence in ourselves. Okay, when the parents ask me, are you sure? I said, I'm not sure. Then they look at me, then why are you talking? I said, I'm honest. To the best of my honest ability, I have given you an advice. It may not be right. Find out who can give you the right advice all the time. Okay, but I tell them that honest advice is usually right. Okay, yeah, and I think that's the way you keep the parents mum. And yeah, when I say this, they don't know where to look at. Then they say, better get out and follow this man because he will talk something more. So I think, I seriously mean that you rarely fail to convince a parent if you try your best and be confident. Okay. And finally, never argue. You say, but so-and-so doctor always gave medicine. That is his view. He may be right, he may be better, but this is my view. I put it on black and white. I think when you say that, when I say no antibiotic, I write it down. And I tell them that if somebody writes an antibiotic, please ask him to write why he has written an antibiotic. I think the message goes very clear. That they come out and say, no, my doctor says this is enough. Okay, name of the child and 2 antibiotics, enough. Because after all, chemist doesn't need to know for what you have given.
Sir, whether paracetamol is safe in acute viral hepatitis?
In the first instance, in a viral hepatitis, typically you don't need much of antipyretic. But if you need one, you can choose a physical measures, or even then you can use a paracetamol. Okay, it's a paracetamol poisoning. The trouble is, in Western world, they don't have TIC-20. an easily available suicidal agent. So therefore they have paracetamol as a suicidal agent. He who wants to take 50 tablets of paracetamol to die, you have many better agents. So I think paracetamol is safe. Western literature highlights the toxicity, fatality, all that is either accidental, more often intentional. I would say paracetamol is safe even in viral hepatitis. Well, if he is in a hepatocellular failure, then that's a different story. Viral rarely does that. I imagine you don't need an antipyretic. When you need, you can use physical measures. If you need at the end of that to use paracetamol, it won't harm.
So at the height of fever, the children doesn't tolerate the moist cloth used for tepid sponging. I think I would suggest the mother's wet hands to smear thin film of water and let it evaporate. These children may tolerate well the mother's hands, moist hands, rather than the cloth that is put on the children. Many children, they get irritated and once the cloths are put on, moist cloths, at the height of fever.
Fine. I think the principle is same. What you are trying to say with your observation, that you have a different modality of putting the same principle in implementation, I think perfectly fine.
So regarding blood culture, what's the right time to take blood culture? Whether
for me, blood, sorry.
No,
Don't
sir.
ask me too many questions. Yeah.
Blood culture should be taken whether the patient at the time of temperature or after the temperature settles.
Blood culture?
Yeah.
Oh, blood culture
Is
you
there
can
any
take at any
specific
time.
time?
It doesn't matter when you take. But for me, a blood culture is a 4-day fever, getting higher, no clue clinically. Salmonellosis is probability. If possible, I would send a blood culture. And I would make a point, and I'm sure he may address that issue, that Salmonella is the easiest organism to culture in a bacteriology lab. If your bacteriology lab cannot do that, they should stop bacteriology lab. Yeah, it's not a Haemophilus influenza we are talking about, which is so difficult. Salmonella is easy, provided you are not given an antibiotic, provided you definitely get Salmonella. Okay, and I think we must develop that culture of asking for cultures. Okay, I mean urine cultures are also often not asked, which is a pity, but blood culture. I don't mind if you don't ask for a culture in pneumonia. But the pneumonia is here and you are expecting the organism to loiter around in the blood there. You are expecting too much. Well, it could be, but it's not a good idea. But a bacteremia, like typhoid, I think what better proof but a culture. But we have already heard him, that culture is not available each time. You go by clinical status, Vidal, etc. Yes. But if you want to do, I think a culture, yes.
So the facilities is not available. It is transported to some other cities. Whether it is advisable, sir?
I think ideally not. For example, ideally, I'm sure the best way, if I have a little bigger child who can oblige, I would ask him to go to the lab and pass urine there and let him collect there, write and plate it immediately. The other alternative is you could keep plates as a clinician and plate it right there. I think that may be ideal. Moment you have a transport and time lag, I think you are causing trouble. But you need to do whatever is best. In my urine cultures, I would ask the parents to take the child to a lab and the lab collects it so that they have no reason to say you sent a wrong sample and here is your wrong result. Till what? What number of days? Oh, till you are sure that there is nothing you are missing. Yeah, I mean, after all, viral infection can go on for a week, if you are sure. But at the end of 4 days, I think you want to be doubly sure. So you would do some preliminary tests. If your blood counts are normal, if your urine analysis is normal, if your chest X-ray is normal, you have already never thought of a meningitis or anything, what more can you prescribe? Just stay put with paracetamol. But surely, 4 days have gone past, you are trading on a little loose grounds and you need to be very sure whether you are looking at some unusual, rare diseases.
So we see viral infections now commonly present everywhere. Infants about 1 to 2 years presenting with scattered crepitations. little faster breathing, but still not pneumonia, because the criteria of WHO says faster respiratory rate. So are we right or are we rational in not exhibiting antibiotic?
Yeah, I think the WHO criteria are largely not to allow any misdiagnosis of a pneumonia. But in your and my hand, you have an experience to back up. You have a chance of follow-up of a patient the very next day. If need be, you have a chance of doing some tests. I think we can be little more rational in making this statement not every time true. And therefore, what Mahesh said, I would agree that if there is hardly any fever, okay, then it's not a bacterial pneumonia. If there is a high fever and a tachypnic child and a grunting child, then we already said that we don't need anything. It's a pneumonia. So I think largely the WHO protocol ensures that every child of pneumonia is referred quickly for treatment, even when some more are unnecessarily treated. That is to reduce the mortality in the population. You and me have an one-to-one contact with a patient. You and me can do something much better, and if one is sure. But yes, if I'm not sure, I'll follow the protocol. It is safe. If I'm sure, I will ignore the protocol. So to ignore the protocol, I need to be very sure. Otherwise, I follow the protocol, I'm okay. Intravenous paracetamol. No. I'm very poor of getting the veins, so I would not try. Now, I think I don't see any reason for intravenous paracetamol. Physical measures are good enough, oral is excellent. So no intravenous medication.
One glad announcement, Professor Amdekar is sharing his experience, lessons learned from the grand rounds. He is releasing a book by name Lessons from the Grand Rounds. The book will be released in January 2005.